Okay, so now I'd like to take some time to pull everything together that we've been looking at so that hopefully it will make sense to you based on an examination and intervention and looking at possible outcomes for your patients. So I think we've talked a whole lot about levels, and you should have a pretty good understanding about levels of spinal cord injury and how that affects both respiration and the bladder. We're also going to look at this from an acute stage of rehabilitation as well as from rehabilitation stages further on down the line. But if you're working with somebody acutely, they are going to have some kind of post-injury stabilization, most likely. So we talked a little bit about whether those orthoses were going to be at the cervical level or if they were going to be more at the thoracic level, and those will provide external stabilization to help promote that healing. They may or may not have undergone surgery. In general, our spinal precautions will be in place unless otherwise stated by the surgeon. So we're going to avoid bending, lifting, and twisting, which does take away some of the techniques that we're going to be teaching the patients. But we need to be able to understand if those devices can be taken on and taken off and put on, and how to do so, and to check for any pressure areas. So now, thinking specifically about the examination, we haven't really talked too much about this cognition, but we have to recognize that a lot of our spinal cord injured patients will also sustain traumatic brain injury at the time of the accident or injury. Therefore, we're going to need to add some kind of cognitive assessment on our evaluation. If it's more mild, or if there hasn't been a diagnosis of a head injury, we're probably just going to rely on observation during the history and interview. But if we feel like we need something a little bit more specific, we'll use the MOCA, and I've got a link there for you to take a quick look at the mini mental state examination, which is also another nice tool that you can use for cognition. We know that we're going to have to be examining cardiovascular changes. And if we're thinking about it from an acute phase, we know that we need to monitor blood pressure very closely, and that may make up a good bit of our treatment strategies where we're working on that patient's ability to tolerate progressive upright positions. Because they naturally have hypotension after a spinal cord injury, and orthostatic hypotension is most likely going to occur, we're going to be maybe using a tilt table. And in addition, we're thinking of that while we're getting them up in a seated position as well. So we might be using a reclining wheelchair with elevating leg rests so that we can slowly progress them to more upright position. Or again, we're using the tilt table. We have to be very careful when we're elevating the head of bed. Remember, if we go up past 30 degrees, that person is going to have a higher likelihood of sliding down in the bed and having some shearing on their skin. So the elevation of the head of bed, we probably are limiting that to about 30 degrees. And after that, we'll be moving into a reclining wheelchair and eventually up into a tilt table. We'll be using things like abdominal binders and ACE wraps or compression stockings on the lower extremities to also help with this. And keeping in mind that we need to monitor for signs of autonomic dysreflexia, which is an emergency situation of high blood pressure. In our exam, we can look at things, of course, like vital signs, but something that we're more familiar with, the 6-minute walk test, we might do a 6-minute arm bike test, which I have an upper extremity ergometer pictured up in the top right corner. We can also use things like a rate of perceived exertion for whatever tasks we're doing, if we're doing mobility tasks or anything like that. And we're also observing for autonomic responses. A more chronic spinal cord injury patient is still going to show some cardiovascular changes. At the cervical level, we're anticipating a lower peak heart rate, post-exercise hypotension, and some abnormal cardiovascular responses that we're going to have to monitor as we go. Below that thoracolumbar sympathetic output, we're also expecting that they may have reduced exercise tolerance with a lower stroke volume and a reduced cardiac output. In addition, depending on what they've been doing since their injury, they could demonstrate overall deconditioning. and we want to get them back to a regular cardiovascular fitness program. But you can see from these considerations that we're going to need to monitor the heart rate and the blood pressure, especially as we're setting up that program for them. Again, the exam looks similar to the acute. For pulmonary function in the acute stage, they might need mechanical ventilation, C3 and C4. As they move along, there is some chance that they can regain some function and only require part-time mechanical ventilatory support if they're able to regain that ability to breathe on their own for some periods of time. Remember, breathing is going to be easier in that supine position versus sitting. So we're also possibly using that abdominal binder to help with that when we get up into sitting. As far as the PT examination goes, we can watch their pattern of breathing. Thinking about that strength of the diaphragm and intercostals, we're watching that maximum, that chest wall expansion like we did in peds, where we measured the amount of chest wall expansion at different levels of the chest. So yay, don't forget that fun stuff that we did. You could also look at things like vital capacity. And of course, we're watching out and assessing their ability to cough. Thinking about the vital capacity, we expect different vital capacity depending on the lesion, the level of the lesion, and you can see that in the box on the right. So for cardiopulmonary interventions, again, we're going to be promoting cardiovascular fitness, probably going to use any abdominal binders or ACE wraps to help decrease that orthostatic hypotension while they're exercising. We're going to facilitate diaphragmatic breathing and that respiratory muscle function, right? So we're really kind of focused on helping them, especially depending on their level, improve the inspiratory and expiratory muscles. We can also be using handheld devices. I think we looked at a few of those in pediatrics last semester, looking at those handheld devices that can help work on those, improving those breathing patterns. Again, you're going to be training caregivers in the quad cough technique, and we can also do some manual stretching of the chest wall. We talked about that last semester as well, looking at that in supine and making sure that we're manually stretching out that chest wall and teaching the patient how to do that on an ongoing basis. So I'm not going to play these for you, but I'd like you to stop the video and go ahead and watch these videos on how to do the manually assisted cough. Other examination components that are our bread and butter are range of motion and reflexes, looking at high muscle tone and spasticity. Okay, range of motion is going to be extremely important. I think we've talked about this. I'm hoping that you can spit these out in your sleep. Right? We really need shoulder extension, elbow extension, wrist extension, either at least full or possibly greater ranges. Okay? Hip extension, knee extension, we need those for standing, and as well as some long sitting and transfers, keeping in mind that we want that hamstring length to about 110 degrees. And we also haven't really talked about this as much, but we want to maintain dorsiflexion for when that person is standing, and also it will help with transfers if they haven't got contractures at the ankle. Also thinking about reflexes, in those early stages we expect hyporeflexia due to the spinal shock, and keeping an eye out for when those are returning will give us an idea of when that spinal shock is resolving. Also, if we see any upper motor neuron signs like hypertonia, clonus, Babinski, Hoffman's, that will give us an indication that we've got resolution of that spinal shock, but also some increased muscle tone developing. Okay, so these are all things that we learned about, and you should be well versed in how to do them: range of motion and the modified Ashworth scale, reflex testing, and looking at the difference between upper and lower motor neuron signs. Thinking about that range of motion from contracture prevention and management, but also we are selectively shortening some things to improve function, like long finger flexors. Any injury above C8, we need those so that the patient can have a functional grasp. And we're really trying to maintain the tightness in that thoracolumbar fascia, which will help them translate movement into their lower body for functional mobility. We may be using orthosis and hopefully keep those, like especially at the ankle, keep that ankle in an optimal position, and either until motor recovery or to make sure that it's maintained through function later. Again, preserving that tenodesis, but anytime we are using any kind of orthosis, we are checking the skin and modifying and increasing the wear time as we go. Some things that we're going to need to stretch, we already talked about. You can read them there. That should make good sense to you right now. The only time we have precautions or contraindications of that stretching is when that would impact an unstable fracture site, especially in that acute phase. So generally there's a healthcare team and you're consulting with the physician regarding those contraindications. We already know this. We're going to be assessing ASIA, so the sensory level of impairment. I'm not going to spend time here because we spent a whole lot of time last week. So just keeping in mind that that's giving us our sensation and thinking about that sensation and the sensation impairments in regards to what sort of skin integrity we need to keep our eyes on. And we're going to think about the immobility and how they're going to be doing pressure relief. Okay. We talked about this way back in clinical practice about how to monitor and what sites you're going to have to monitor anywhere there's bony prominences. And I think you're pretty good at this. Just keep in mind that we don't often think about the back of the head as being a place where we're going to have to monitor skin. So this patient population is going to be extremely important to either think about. They might in the acute phase have an airbed that will do the rotation and the movement for them. But once they don't have that, you're going to need to talk to them about relieving pressure. Okay. And again, we're doing the ASIA impairment scale for sensory testing, and we're looking visually at the skin on those places that might get pressure. Some of the things that we might use are that multi-potus boot. We talked a little bit about that last semester and showed you one. If you want to see it again, I'm sure we can dig it out of the closet. That's going to help not only for the skin care, floating those heels, but it will also help keep the ankles at a 90-degree angle. Again, the head of the bed shouldn't be elevated greater than 30 degrees, so we don't have them sliding down and creating friction, especially in the sacral area. Again, they're likely to have a air bed, but in the wheelchair, it's going to be part of our job to teach them pressure relief as well as skin inspection, and we can use, our OTs will probably have long-handled mirrors for us to use with that. And we're either teaching them how to do pressure relief strategies in their wheelchair and in the bed, or we are making sure that they have those devices, either an air fluidized bed or a tilt and space wheelchair that can relieve the pressure for them. You can set good examples by building these into your intervention sessions every 20 minutes or so, having them do another one. Okay, this is a nice graphic because it shows, of course, the one that we all think of is down here in the bottom left, where we just teach a wheelchair push-up, but not all of our patients are going to be able to do that or do that effectively. So these are some other nice positions that you can teach people that they'll be able to independently relieve pressure. And you want to teach them to do that for about 2 minutes at a time. Another thing that we have to think about with this population is pain. So there may be other musculoskeletal issues that happened when they sustained the initial trauma. So you're going to be addressing those. They may also have or develop central neuropathic pain. But a lot of times we see wheelchair users, manual wheelchair users especially, develop shoulder pain. And we've talked briefly about this. But this is a nice little study that demonstrates that we're able to reduce the amount of pain because these individuals, I think somebody brought this up, we can't just say, stop doing your transfers. So they're not going to be able to stop doing their transfers or their ADLs while they're recovering. But it does show that with use of exercise, you can help to lower the amount of shoulder pain while they're doing those the things that they need to do every day. Okay, so this is a nice index, the wheelchair user shoulder pain index. I'm giving you this because you'll likely, if you're working in an outpatient facility, you're likely to see a wheelchair-dependent person for shoulder pain. And so this makes a really nice outcome measure specific to that. We also have to remember that they're going to have difficulty with thermoregulation, especially those cervical level injuries and those with complete injuries. Acutely, they might be hypothermic due to some vasodilation, but in the chronic stages, we're really teaching them to watch out for hyperthermia. They have that lack of sympathetic control over their sweat glands, so we might need to give them some strategies to use if they're going out in the community in the summer. They have some vests, some cooling vests that patients can get that are quite effective, especially they were designed for mascots to wear underneath their uniforms, so they're pretty effective. So they may need to have strategies like that to be out in the community during hot temperatures, and we're especially thinking about that with our quadriplegic patients. We know that we're assessing the motor level with Asia. Again, we're testing all the key muscles, and we might want to think about the fact that even though there's only certain situations with Asia that we test the non-key muscles, we may also want to keep an eye on them to see if we see any movement coming, especially in those first short time periods. During the acute phase, we may be checking Asia once a week to see if we have more function coming than we initially thought. We might have initially thought it was a complete injury, and over time that may change. They may also start to develop again, some more movement, especially with the incompletes. We're trying to really watch that because we want to gear our interventions to maximally strengthen everything that shows the smallest flicker of movement. Okay, so that's the importance of zone of partial preservation and whatever movement that we can see in a patient that has an incomplete injury. Okay, so we're always keeping an eye out for whatever movement that we see coming along. We do also have to be cognizant that they might have suffered additional injuries and help with remediation of those problems. And keeping in mind that we might have some precautions due to the spinal instability. Some substitutions that you might see or that we might teach the patient to help them be able to compensate. So initially, you might want to watch out, especially if we're trying to strengthen things, you might want to watch for substitutions that come along. But again, sometimes we're teaching substitutions to help the patient get more movement or more function during functional mobility than they would typically have. So these are some things that we do teach patients to help them be able to move. Part of our job is going to be to strengthen anything that's innervated. And you might use, these are nice push-up bars that you can use to help train patients to get that extra push plus on their serratus. Again, we're going to preserve that tenodesis. We're focused on muscle recovery if at all possible. So any muscle with innervation is going to get strengthened. So we're keeping an eye on those non-key muscles as well. So with a patient with Asia A, you can see that they might get some recovery over time in their strength to a grade 3 or better, which would be a functional difference for that person. So that does it for most of our body structures and functions examination. In the next part, we'll be moving on to mobility skills and balance.